Well, good day, everyone, and welcome. We're so glad that you joined us today. This is the ISMP Symposium, a call to action, dedicated medication safety transformation in the perioperative setting. And I'm Chris Mahalik, a pharmacist with the Institute for Safe Medication Practices, and I'm going to serve as your program moderator for today. Before we begin, I would like to thank Pfizer for their support of this program. As you know, the perioperative and procedural environment is high risk, fast-paced, and complex. And it's where medication errors may lead to a disproportionately more harmful outcome when they occur. Today, we're going to focus on current issues in the perioperative medication safety space and ways that you can prevent harmful adverse drug events. Some of the problems we'll be talking about often go unrecognized and in our experience are not being adequately addressed by many healthcare organizations. Our speaker team will highlight some of the risks that sites participating in our ISMP medication safety self-assessment for the perioperative setting have identified, and we'll discuss the best practice guidance that will be developed as a result of our National Invitational Summit. Before I introduce the speakers, just a few housekeeping details. The materials that you received for the program include the slide sets for today, as well as instructions on how to obtain your continuing education credits. At the conclusion of the program, we'll be giving you an attendance code. You're going to need to use that attendance code to complete the online evaluation in order to receive your educational credits. So now on to our speakers for today. Our first speaker will be Dr. Julie Boynton. Dr. Boynton is a nurse practitioner who focused her doctoral research on an interdisciplinary approach to improving perioperative medication safety. Her work was completed in conjunction with the Institute for Safe Medication Practices, and it concentrated on the prevalence of medication errors in the perioperative area. Julie continues to seek opportunities to improve medication practices through presentations and publications, and she shared her work at local, state, and national conferences. Our second speaker today will be Judy Smetzer. Judy is one of ISMP's vice presidents, and she's a nurse by training, and is one of the primary authors and editors of ISMP's 5 newsletters. Judy has helped conduct studies associated with medication safety, which were funded by AHRQ and FDA, including the ISMP medication safety self-assessments. Judy is a certified trainer in Just Culture and has received a number of awards, including the Avitas Donabedian Award from the American Public Health Association and the Way Paver for BPOC Award from the Terra Pharma Project. And she was the first nurse recipient of the ASHP Board of Directors Award of Honor. And finally, our third speaker today will be G. Mathen. G is Director of Pharmacy Clinical Applications and Technical Services at Texas Children's Hospital. G has devoted over 28 years of his career to improving patient safety with the use of technology. Some of his recent activities include leading the standardization of automated dispensing technology, along with implementation of IV and inventory robotics. G has been the user group president for Cerner Megasource, BDM, and GE Centricity, and he served as secretary for Omnicell's Thought Leadership Group. He's also worked closely with Epic to help develop several modules. So please join me in welcoming our speakers for today's program. Now I'd like to turn over the podium to Dr. Julie Boynton, who'll begin our program.
Hi. So welcome behind the OR doors to the perioperative area. I'm a nurse anesthetist or CRNA by training. And so I provide anesthesia on a daily basis in the operating room. And I know that coming behind and through the OR doors is not a place that we are always welcoming. And sometimes it's intimidating to come. But welcome and come inside and see a little bit more about perioperative medication practices and what's actually going on. Next slide, please. I don't have any conflicts of interest. Next slide, please. So we all have a story to share. If anybody has been doing anesthesia for very long or in the perioperative area for very long, and they tell you that they haven't made any errors, they're not telling the truth or they just started. There are plenty of errors that are made. In fact, the error rate ranges from 1 in every 20 administrations to 1 in every 2,000 administrations, depending on which review you read and whether it's an observational or a self-reporting study. So I'd like to share a couple of stories with you. Next slide, please. So as you see, this is a bunch of medications. I was doing a call to do an emergency appendectomy, remove the appendix on a young 17-year-old male. And in the drug tray, this particular tray doesn't show up, but to give you an idea, the drug tray had the neostigmine and the succinylcholine right next to each other. And I was quickly preparing medications to get ready. Both had red tops, and I grabbed the neostigmine. And as I drew up the neostigmine, it was only a double check of the label to read that said neostigmine instead of succinylcholine. And we all know that had I administered the neostigmine instead of the succinylcholine on induction, that would not have gone well. So that's one example of a having the drug placement being particularly important, how the vials being laid in the tray. That's actually the error that made me become very interested in medication practices, how things are provided, and what we can do to improve the environment. Next slide, please. Another day I was working, and actually I had seen this reported in an APSF report shortly before this occurred. I was working in the cath lab, got ready to put the patient to sleep, went to pick up the vial, and I had Rotaglide sitting on my anesthesia machine that I had not put there. These are there's only a few white milk-like medications out there. These two occur in the cath lab frequently, but the Rotaglide should never make it close to the anesthesia machine. I actually never picked up the Rotaglide, but it became incredibly apparent that since propofol is the main medication we give in the cath lab, that this error is very easily could occur with other people. The labels are very similar, the vials are very similar, the size is exactly the same. And as you'll hear, anesthesia relies a lot on routines. And yes, we should double check and read labels. And yes, we should label everything. But we're working in a very fast moving environment. And so the room for error is greater. Next slide, please. So what is the process and how does it work? Well, after a summit that the APSF put on, they found that in the process of administering a medication in the OR area, there are 42 steps to administer one medication in the operating area. And that includes from the time the anesthesia provider decides they're going to give a medication to the time that they actually administer. So that's the prescribe, secure, prepare, administer, and documenting phases of the medication. And that's just one. On average, in a general anesthetic at a very basic level, there are 5 to 7 medications given. And usually there are many more medications given. So at 7 medications, that would be 287 steps that are in a process to give all those that are gone through to give 7 medications. That does not include the process that it takes to actually get the medication from when it enters the door of the hospital at the loading dock or however it comes in, all the way through the pharmacy, loaded into the automated dispensing cabinets or medication trays, and then administered. There are approximately for each medication between 250 and 300 steps to get that medication into the OR, and multiple people involved in that process: pharmacy techs, pharmacists, anesthesia providers, nurses. There's the person who's bringing the medications from the loading dock, a whole lot of people that are involved in this process. And usually the process or the error is not the result of one person's mistake, but the result of many lapses within the system. Next slide, please. So the process is complicated. In an effort to try to simplify the process, I came up with this process example. This by no means is any example of how a medication makes it from when it arrives at the hospital all the way until dispensing. There are pieces of it that may be deleted or not done, and many times there are many more pieces to it. At first attempt at drawing a process, knowing all of the complicated pieces that go into this, it looked much like a roadmap that was going in a bunch of circles and lots of loop-de-loops. And I think that happens on a daily basis. There's who dilutes the medications, who reconstitutes it, do they get drawn up in the OR, do we have pre-filled syringes, are there medication shortages? All of those are going to contribute to this medication process and how it is complete. Next slide, please. So what are the contributing factors to medication errors? Well, you can see right here, based on the literature, you can divide it up into types, causes, human factors, environmental factors, and characteristics. Some of this can be confusing because there are not necessarily clear definitions of these, and so can be a little gray area in whether something is actually a cause or a type. But let's look at some of those error rates. Next slide, please. So patient characteristics. In a literature review, it found that over 10 studies, the acuity of the patient actually was not statistically significant in contributing to the error rate, although they did notice that the healthier patients and the younger patients, but not considered the young pediatrics. So in the 17 to 20s age group actually had the highest incidence of error because they're considered to be probably the healthiest and quote unquote easiest patients to take care of. Male patients had a slightly higher rate of error, but not statistically significant either. So a lower physical status score or ASA score and young healthy, as we like to call them, had slightly more, but nothing statistically significant in this area. Next slide, please. Environmental factors. Changing the number of providers within a case. Every time the provider changed, the risk of error goes up because there can be information lost within translation. Federal hospitals or facilities and hospitals with 100 to 499 beds were the hospitals that had the statistically significant higher rates of errors in them. And then while we're talking about the error rates, an error can cost a hospital anywhere from $600,000 to $6.5 million a year if you're calculating cost of medication errors. And 1/3 of medication errors can cause some sort of patient harm. That can be in the OR. There's a little bit of gray area here too, because your provider may make an error, but can quickly recover with another medication. For instance, causing severe hypotension, or giving something that they're allergic to, but then can give a medication to treat those reactions. So the fragmentation of care, the length of surgery, any surgery over 2 hours, and even more so after 6 hours, had a statistically significant increase in medication errors. That's also usually due to environmental factors. Then in transfers of care, whether that would be from the ICU to the operating room, or from the operating room back to the ICU or the floor, there were incidents of error, usually related to changes in concentrations for IV drips. A lot of times the operating room has a different concentration that they use. The bag gets switched at the top, but the pump doesn't get adjusted. And then different doses being given, and the patient has a reaction. There is the initiative to standardize for safety that ASHP has, and that has definitely helped with decreasing this error. Next slide, please. Incorrect dose, omission, and substitution are the highest, along with labeling, which is in the next slide, but are the highest cause and most common causes of error. They account for 70% of all medication errors. What does incorrect dose mean? That just means giving the wrong amount. That could be as simple as, it's usually the movement of a zero that causes this particular error. It could be usually related to a dilution error as well. Maybe you only dilute the phenylephrine comes in a high concentration. Maybe it's diluted in a hurry and it's not done correctly. In a study actually of ICU nurses, they they put them in an emergency situation and noted that 45% of the time they did not dilute the medications correctly, leading that if at all possible, pharmacies should be providing pre-filled or mixed medications in the perioperative area as much as possible, because we are in that intense quick calculation place often. Next slide, please. Communication. Communication can be with the surgeon, with the OR staff, between providers. There's lots of ways that the surgeon is always communicating with the anesthesia about what they need or how we can help them, or they may ask for a medication. You can easily misunderstand them, especially with all of the mask and sometimes in orthopedics, even the suits they wear, it's hard to understand what they're saying. So it's important to definitely repeat back or clarify if there's any question. It could also be a miscommunication between providers about what has or has not been done. Knowledge deficit, it kind of comes with the territory. Unfortunately, people in the operating room, whether it's the nurses or the surgeons or the anesthesia providers, are under high pressure and nobody wants to be wrong. And 35% of errors are related to some sort of knowledge deficit. So maybe the wrong dose is given, but the knowledge of what dose to give, maybe for a medication that is not used frequently, was unknown. And instead of asking, or maybe there wasn't time to quickly look it up, somebody just doesn't know. So we need to create an environment where it's okay to ask questions and it's okay to communicate with one another. And then labeling is right up there at the top of the list of medication errors. It is in that top 70% that contribute to error. Labeling can be how the vials are labeled. When the vials, excuse me, look very similar, maybe, or the cap, and all that's different is the cap color, or maybe they look exactly the same. There, for instance, right now, there is a vial of tranexamic acid and a vial of rocuronium that look exactly the same. They're the same size, they have the same coloring on their label, and they have red caps. And I have seen 4 reports in the last 2 months of people having tranexamic acid in their rocuronium or vice versa. And I've seen 2 reports of people giving one of the medications instead of the other. So they gave the tranexamic acid instead of the rocuronium or vice versa. There have been no patient harm caused by either of these, but there is definite potential for this. So when there are like vials, they need to be away from each other. They need to be labeled well. The same for the syringes. If the pre-filled syringes can look the same, or the way they are labeled in the operating room can look the same, we still have to do the double check. Next slide, please. Human factors. We work in a high stress environment. We do things very quickly. Induction and when the patient's going to sleep, or at the end of the case when we're waking them up, are the times that the air is probably most likely to occur. Fatigue. If your fatigue, pressure to proceed, and vigilance can all go together, especially the fatigue and the vigilance, the longer we work without a break, the harder it is to focus. Though surprisingly, the majority of medication errors in this category occur between 7 a.m. and 11 p.m. When we know we're really tired and we're doing an emergency in the middle of the night, we are actually less likely to be making errors because we are acutely aware that we are tired and that there is a chance for error to occur, and that we believe that that chance could be higher, unlike at 7 a.m. or during the day. There's a lot of hurry up, and anesthesia doesn't like to be the person that you're waiting on. And so at the beginning or the end of the case, there is pressure to proceed. Or if the patient becomes hypotensive or hypertensive, where there's a lot of bleeding and there's complications within a procedure, the team is relying on the anesthesia providers to help with all of this. Next slide, please. So where do we start in this process, and how do we get to making medication practices and improving them better? Well, it's a collaborative effort, and we definitely need you, the pharmacists, to be involved. One, come back there and work with us. You're going to have to find your leaders to know to self-start it and to start those conversations. It starts with simple answers like maybe reorganizing the automated dispensing cabinets or the medication trays into a friendly, more friendly user way, and being conscious of how medications are placed. And then as you start to make progress, then you build your team and open the conversations, you continue to improve. Another way that Judy is about to discuss is the perioperative self-assessment that has been created to help look for lapses that could occur in the medication system and give a way to identify where there may be weaknesses in the medication practices or system in your facility. Next slide, please. The goal, of course, with everybody is to have create a safe environment for everyone in the area and to work together. Next slide, please. So labeling would be one of the key areas that we're going to discuss. You can see the rocuronium and the tranexamic acid vials that I showed you here. And then these are examples of a syringe that has barcoding on it so that we can implement barcoding. And then we also have to overcome some of the labeling issues that we've seen for a long time. Next slide, please. Barcoding can mean, and one of the issues that we need to identify is, what does that actually mean? Does it mean barcoding the ID band? Does that mean barcoding the medication as we print the labels? Does it mean barcoding the medication from the vial? Or does it mean barcoding, how do we implement barcoding to scan labels and get it documented within the electronic health record? So there's a lot, when we talk about barcoding, we need to be clear about what we actually mean in that. Next slide, please. And here's an example of how barcoding could be done, all the way from scanning the syringe, hearing having an audible as a double check, and then going back to the electronic health record. Next slide, please. Smart pumps and smart pump technology and the potential for a double check within the pharmacy, or limits within the smart pump, is also another way that we can look at helping correct the errors. Next slide, please. The goal in all of this is, as you improve your process, you want to help keep your process simple. Adding a bunch of steps doesn't necessarily improve a process. So simplicity is sometimes the ultimate sophistication, or making it better. Next slide, please. And then lastly, I would encourage everybody to remember that collaboration and collaborators are all together, and we need to work together, but even in the dictionary, collapse is right under it. So if we choose not to work together and not to attend this as a goal together, then we will not make progress. So I strongly encourage you to collaborate with anesthesia, nursing, pharmacy, all together to improve this process. Thank you very much.
Good afternoon, everyone. I am Judy Smetzer. I am the Vice President at Ismb, and I'm going to summarize the early national aggregate results from the Ismb Medication Safety Self-Assessment for the perioperative setting. Next slide. I have no conflicts of interest to disclose. Next slide. I'll begin my presentation by briefly reviewing the perioperative assessment tool. Then I'll describe the preliminary demographic characteristics of participating national facilities to date. And then I'll spend most of my time highlighting the preliminary practice and system risks discovered by the inpatient ambulatory surgical centers that participated in the assessment so far. But please be aware, the assessment provides a lot of data, and I'll only be able to cover just a small smidgen of the data that we have to date. I'll close my presentation with an examination of the Ismb best practice guidance that we're planning to help hospitals and ambulatory surgery centers begin the transformation towards meaningful medication safety improvements. Next slide. So I'll start by describing the perioperative assessment tool and the assessment process. Next slide. The Ismb Medication Safety Self-Assessment for Perioperative Settings is a project funded by the U.S. Food and Drug Administration. It was launched in mid-May 2021, and it provides a standardized way for both hospitals and freestanding ambulatory facilities to assess the safety of their systems and practices associated with medication use during every phase of the medication use process in the perioperative setting. It's intended to help organizations pinpoint how currently designed systems, staff practices, and emerging challenges might impact medication safety, and thus help those organizations create organization-specific safety-focused initiatives to improve medication safety in the perioperative setting. It's our hope to also create a baseline of national efforts to keep patients safe from medication errors during all phases of the perioperative medication use process. The assessment includes 221 best practices which are divided into ISMP's 10 key elements of medication use. But please keep in mind, ISMP is not a standard setting organization. As such, the assessment items or best practices are not held out to represent a minimum standard of practice. In fact, some of the items represent innovative practices and system enhancements that are not widely implemented. In other words, stretch goals. But their value in reducing errors is grounded in research and expert consensus, and we've seen the practices fully implemented in some facilities. Thus, we believe they're all feasible. Each assessment item is weighted, given a score of 0 to 16 based on its impact on patient safety and its ability to sustain improvement. The weighting system allows facilities to prioritize best practices based on their impact on safety. Importantly, the weighted scores are not viewable during the assessment, and only facilities that submit their results to ISMP receive their weighted scores and the maximum weighted score for each item. Next slide. So participants were given a 5-point Likert scale, A through E, to evaluate their level of implementation with each best practice item. A represents no activity to implement the best practice. B means that the best practice was discussed but not implemented yet. C represents partially implemented best practices for some or all patients, orders, drugs, staff. D represents fully implemented best practices for some patients, orders, drugs, or staff. And E represents full implementation for all patients, orders, drugs, or staff. For the purposes of presenting the preliminary results, I've grouped all the data into these 3 categories on the slide. A and B, which means no implementation of the best practice. C and D, which represents partial implementation of the best practice. And E, which represents full implementation of the best practice. Next slide. Right now, the assessment is ongoing. Organizations still have till Friday, December 10th to submit their findings to ISMP. What I'll be describing is the preliminary data that we've received up until November 30th, a little more than a week ago. Based on our prior experiences with self-assessments, I think this is our 7th self-assessment, we tend to get most of the submissions of assessment findings during the last few weeks that the database is open. Currently, we have more than 1,000 assessment accounts created and about 500 facilities that have sent us their demographics, and more than 400 additional facilities that have started entering their demographics online. We anticipate that most of the facilities that have sent us their demographics will also be sending their assessment findings to ISMP. We know that every healthcare provider is so busy with the COVID-19 pandemic, but if your organization has completed or has nearly completed the assessment, please encourage staff to submit their findings to ISMP by Friday, December 10th. Next slide. So to start, I'd like to describe the respondents that have already submitted their data to ISMP. Next slide. Up until November 30th, there have been 159 respondents who have submitted their full findings of the assessment to ISMP. That's 124 hospitals and 35 freestanding ambulatory facilities. That's 78% hospitals and 22% of the ambulatory facilities. Most of the ambulatory facilities are ambulatory surgery centers. We've only had 2 other facilities that are physician practices that perform procedures in the office. By the way, we currently have 201 facilities that have sent their findings into the database, 158 hospitals and 43 ambulatory sites, with the same split, 78% are hospitals, 22% ambulatory. And we found that the percentages change very little after maybe 150 pieces of data. Next slide. To give you a snapshot of the hospitals that have submitted their data to ISMP already, The respondents are pretty evenly split regarding bed size, but there are fewer very large hospitals. As with the national profile of hospitals, most hospitals across the US are smaller hospitals. These 124 hospitals mostly serve a combination of adults and children. Most respondents, most of the hospitals have under 10 or 10 to 39 ORs. Very few have more than 40 ORs. And most hospitals have performed up to 20,000 OR procedures per year. But keep in mind that nearly 1 in 5 hospitals has performed more surgical procedures than 20,000 per year. Next slide. Almost all the respondents have less than 40 procedure rooms. Remember, these are hospitals, and have performed up to 2,000 or 20,000 procedures in these rooms per year. 88% of the 124 hospitals reported the availability of barcode scanning. In the demographic questions, we only ask about availability. We don't ask about implementation or use of the technology, just is it available? So 88% of these 124 hospitals reported that they have barcoding scanning capabilities available in the perioperative setting. For the 88% that reported barcoding technology availability, it appears that it's mostly available in the holding area and the recovery area, but more than 1 in 3 hospitals reported availability of barcoding technology in ORs and the procedure rooms. In fact, 48% said it was available in procedure rooms. 94% of the 124 hospitals reported the availability of smart pumps with dose error reduction system. We abbreviate that as DERS. Of these respondents, availability of the smart pumps is pretty much evenly split between the holding area, the ORs, the procedure rooms, and the recovery area. Next slide. For the 35 ambulatory facilities, most have up to 500 patient visits per month, although more than 1 in 4 ambulatory facilities reported more than 500 visits per month. No ambulatory facility that sent their response in so far serve only pediatric patients. Most serve a combination of adults and children, or only adults. Most ambulatory facilities have 1 to 3 ORs or 1 to 3 procedure rooms. And you can see that very few have more than 10 ORs or 10 procedure rooms. Next slide. Most ambulatory facility respondents perform 1,000 to 4,999 procedures per year. Only 11% of ambulatory facilities reported that barcoding technology is available in the perioperative areas, mostly in the holding area and the recovery area. And only 34% of the ambulatory facilities reported that smart infusion pumps with DERS is available. And that happens to be mostly in the OR and the procedure rooms. Next slide. Next, I will describe the low scoring findings from these 159 facilities, which represent significant opportunities for improvement. Next slide. So the mean percent score achieved on the entire assessment is 78%. This representation, the 78%, is on a scale of 0 to 100%, much like a report card. So hospitals scored slightly better than ambulatory facilities, but not much, 78% versus 76% respectively. Next slide. The 221 self-assessment items are grouped into ISMP's 10 key elements of medication use. Key element 1, you can see the key elements 1 through 10 underneath the bar graphs. Key element 1 deals with patient information, things like items related to age, weight, allergies, vital signs, pregnancy status, even the patient's identity and monitoring information would fall under patient information or key element 1. Key element 2 deals with drug information, and best practices in that grouping include how drug information is presented on medication administration records, on drug references, on computer screens, and the accessibility of pharmacists to provide drug information. Key element 3 deals with communication of drug orders and other drug information. And the best practices in this section allow participants to assess ambiguous orders, incomplete orders, misheard or misunderstood orders, and it allows them to assess their interaction between staff and the possibility of intimidation. Key element 4 deals with drug labeling, packaging, and nomenclature. And best practice items look at strategies for lookalike names, lookalike packaging, and labeling of medication containers. Key element 5 covers drug standardization, storage, and distribution. And best practices grouped under that key element are associated with pharmacy dispensing, storage of medications, missing doses, standardized concentrations, and standardized processes. Key element 6 involves medication delivery, device acquisition, use, and monitoring. And best practices grouped under that are associated with device design, all different types of medication device design, tubing misconnections, how to prevent them, programming and misprogramming, infusion pumps, syringes, dosing cups, things like that. Key element 7 deals with environmental factors, workflow, and staffing patterns, which deals with lighting, noise, clutter, interruptions, staff deficiencies, workload, worker safety, things like that. Key element 8 covers staff competency and education, including validation of competency, orientation programs, types of educational programs, medication error feedback to staff. Key element 9 covers patient education, the types of educational experiences you provide to patients, the patient's compliance with those instructions. And then key element 10 covers quality processes and risk management. And these best practices mostly deal with verification systems like quality control checks, independent double checks for certain high alert medications, automated verification like barcoding, scanning technology, culture, just culture, safety culture, error reporting, things like that. So the 4 key elements that achieve the lowest score in the self-assessment are circled in red and include key element number 2, drug information, key element number 6, medication delivery device acquisition, use, and monitoring, key element 7, environmental factors, workflow, and staffing patterns, and key element 10, quality processes and risk management. And I'll be presenting the findings of the 2 lowest scoring items in each of the 4 low scoring key elements. Next slide. I'll start with key element 2, drug information, which achieved a mean percent score of 68% overall. Remember, this is on a scale of 0 to 100%, so 68% is the mean percent score achieved in that whole area. Next slide. Item 42 scored the lowest in this key element. This item deals with preference cards for practitioners, evaluating whether they're clear, concise, electronic rather than handwritten, and approved and updated annually. Overall, we only had 24% of facilities that reported full implementation of that best practice. 40% reported partial implementation and 36% reported no implementation. Ambulatory sites scored a little bit better than hospitals in this self-assessment item. Item 36 scored the next lowest under drug information. This item deals with pre-op and post-op orders and whether they're verified by a pharmacist, either remotely or on site before a medication administration. Overall, we only had 39% of facilities that reported full implementation, 36% reported partial implementation, and 25% reported no implementation. In this case, hospitals scored a little bit better than ambulatory sites, since ambulatory sites may not have even a pharmacy on site, let alone a pharmacist. Although you can see that only 48% of hospitals have all pre-op and post-op orders verified by a pharmacist before administration. So even in hospitals, our scores were low. Next slide. The next lowest scoring key element is key element 6, medication delivery device acquisition, use, and monitoring, which scored a mean result of 70%. Next slide. Item 149 in this key element scored the lowest and deals with planning for implementation of NERFIT for neuroaxial connections to reduce the risk of misconnections. NERFIT connectors are unique ISO-compliant non-Luer connectors for neuroaxial applications, which are currently on the market. Overall, we've had 20% of facilities report full implementation, 7% reported partial implementation, and 73% reported no implementation. Ambulatory sites scored a little bit better than hospitals. However, 73% of the participating ambulatory sites do not administer neuroaxial medications or solutions and chose not applicable for this item, compared to only 3% of hospitals. So we didn't have enough data to really make a comparison, a useful comparison. Item 134 was the next lowest scoring item in key element number 6, which deals with the labeling of access lines with the drug name and the route of administration at the distal end closest to the patient and above each pump channel. Overall, we only had 30% of hospitals that reported full implementation, 37% that reported partial implementation, and 33% reported no implementation. Ambulatory facilities scored a little bit higher than hospitals with full implementation, but hospitals had greater partial implementation. But you can see that almost half of ambulatory sites and more than a quarter of hospital sites do not appear to label any access lines in the perioperative setting. Next slide. Although not the lowest scoring item in key element 6, I wanted to share the results of an item associated with implementation of smart infusion pumps with DERS. So if you remember, 34% of ambulatory facilities reported smart infusion pump availability with DERS, and most of these facilities reported full implementation of the technology for both continuous infusions and intermittent secondary infusions. But 94% of hospitals reported smart infusion pump availability with DERS, which was widely available in all peri-op locations, the OR, the procedure rooms, the holding areas, the recovery areas. But there is much less full implementation of this available technology in hospitals. So 70% for continuous medication infusions and 60% for intermittent secondary infusions. So some, not all facilities that have smart pumps available are using it in the perioperative setting. Next slide. For key element 7, environmental factors, workflow, and staffing patterns, which had a mean score of 75%. Next slide. Item 157 was the lowest scoring item. This item deals with designing and following a fatigue reduction plan for practitioners who work overtime, including on-call practitioners in the inpatient setting. Overall, 50% of the facilities reported full implementation, 21% reported partial implementation, and 29% reported no implementation. Ambulatory facilities scored a little bit higher on full implementation of this best practice, but they also scored higher on no implementation than hospitals. The lowest scoring item in key element 7, the next lowest scoring item in key element 7 deals with limiting the use of mobile devices and the internet to patient care related activities as opposed to personal activities. Overall, 55% of hospitals or facilities reported full implementation, 35% reported partial implementation, and 9% reported no implementation. Ambulatory facilities scored a little bit higher than hospitals for this best practice. Next slide. The last low scoring key element I'll cover is key element 10, quality processes and risk management, which achieved a mean percent score of 76%. Next slide. Item number 203 was the lowest scoring best practice in this key element. This item deals with implementation of barcode scanning technology prior to administration. Overall, in the holding areas and the recovery areas, 59% of facilities reported full implementation, 13% reported partial implementation, and 28% reported no implementation. Overall, in the OR and procedure rooms, only 12% of facilities reported full implementation, 22% reported partial implementation, and 66% reported no implementation. So hospitals scored higher than ambulatory facilities for implementation of barcoding in the holding areas and the recovery areas, but you can see that both hospitals and ambulatory sites scored low for implementation of the technology in ORs and procedure rooms. The second lowest scoring item in this key element was item number 206, which deals with performance and documentation of independent double checks for facility-defined high alert medications and facility-defined steps like handoffs, bag changes. So we're looking at following facility-defined policies for requiring an independent double check. Overall, 47% of facilities reported full implementation, 39% reported partial implementation, and 14% reported no implementation. Ambulatory facilities reported higher compliance with this best practice for full implementation, but hospitals reported higher compliance with partial implementation. Next slide. So there were 40 additional items with scores of 50% or lower. That's almost 20% of all of the assessment items. So there's a lot of areas for improvement. I'll just mention 7 of the lower scoring items. And I'm only going to mention the topics associated with each, but you can see on the screen that I've provided you with the combined mean percent scores for both hospitals and ambulatory facilities. Next slide. So low scoring item number 9 deals with determining the opioid status and whether an adult patient is at high risk for respiratory depression. Item number 40 deals with reminders to evaluate the need to resume an anticoagulant that has been held for a procedure that's been postponed. Item 70 is related to medication storage in the perioperative setting, including anesthesia carts being label up, not cap up, so the labels can be read. And low scoring items 17 and 18, the percentages were very close, so I combined them. They deal with the need for continuous electronic monitoring of both oxygenation, which is pulse oximetry, most often, and the adequacy of ventilation, which is most often capnography, for patients receiving moderate sedation, monitored anesthesia care, regional anesthesia with an opioid, general anesthesia, or continuous or intermittent IV or neuraxial opioids. Next slide. For item 142, you can see that most facilities do not review the data from smart infusion pumps for compliance with DERS, for alerts, or to ensure action plans have been developed when necessary. Low scoring item 115 is a best practice associated with interactive ABCs that require the entry of clinical information in the holding area and the recovery area, like if you're going to use a neuromuscular blocker in those areas. And then item 168 deals with staff receiving information about medication errors and error prevention strategies at least quarterly, and 30% reported that this is not done. Next slide. We presented this data at a recent invitational national summit of perioperative experts, and we plan to develop a consensus-based safe practice guidelines based in part on the summit. So I'd like to spend the last few minutes reporting on the summit and the anticipated guidelines. Next slide. So on November 10th and 11th, we held a national invitational summit on the future of perioperative medication safety. The summit was sponsored by the Anesthesia Patient Safety Foundation, various periop technology vendors, and pharmaceutical companies interested in perioperative safety. We had more than 80 key stakeholders attend the summit, including frontline practitioners, providers, and experts from both inpatient and outpatient facilities, key representatives from regulatory and professional organizations, everything from the American Society of Anesthesiologists to the Association of Perioperative Registered Nurses, and then a few of the sponsoring technology vendors and pharmaceutical companies. The purpose of the summit was to explore current barriers to the adoption of known medication safety practices and to identify future opportunities to advance safety in the perioperative setting. During the summit, medication-related safe practice guidelines for the perioperative setting were formulated through a consensus development process, including a pre-summit survey, live summit polling questions, and the recommendations. We asked them for a wish list of key safety strategies by summit attendees. We're currently in the process of developing a set of guidelines for the perioperative medication safety based in part on the consensus of the participants of the summit, but also through a thorough literature search, data from our error reporting systems, and data from the perioperative self-assessment. And we hope to have a draft set of guidelines out for public comment by late spring and the final set of guidelines by late summer 2022. Next slide. So what might the guidelines include? While the final guidance is not yet fully developed, it will likely include best practices that had high agreement at the summit, and especially those that are unique to advancing safety in the perioperative setting. Things like barcode scanning in the perioperative areas, making antidotes readily available, continuous monitoring of both oxygenation and ventilation in patients receiving sedation or anesthesia, things like that. But I can also share with you just a few other safety topics that will likely be advanced through the guidelines, such as the elimination of handwritten syringe labels in all perioperative settings, including the OR and procedure rooms by 2025. Further advancement of medication safety technologies in the perioperative setting, perhaps in the OR and procedural areas themselves. Continuous monitoring of oxygenation and ventilation, not only for patients receiving sedation and anesthesia, but also for patients receiving intermittent continuous opioids. Enhanced pharmacy support in the perioperative setting, improved medication storage and distribution processes, and standardization of products concentrations to avoid customized solutions. That last bullet point, standardization, was repeatedly on the summit participants' wish list of best practices in the perioperative setting, as was error reporting and the further advancement of technology. Recognizing the continued increase in surgical procedures in the ambulatory setting, these new guidelines will be applicable to both hospitals and ambulatory surgeries and procedural sites. Next slide. I think that's the end of my presentation, and we'll take questions at the end of the program.
Hello, well, that was very informative. So I'm going to jump right in and talk about advancing technologies. Dr. Boynton talked about what we are seeing in, in the OR setting, and Judy talked about what we want to see in the settings and what's really going on in the country. So I really want to take some time to look at technology as the future, and the future is now. Next slide. So in 2010, APSF called for a new paradigm. And we knew at that time that we needed to move forward with using technology, because every administration of drug in an OR was a potential for error. And out of that, 1 in 250 resulted in a fatal event. Next slide. So at Texas Children's, we started with the way that many people started. We started with handwritten labels, as you can see, no labeling requirements, no concentration. Manual labeling leaves room for human error. Barcode technology reduces that error, so we wanted to try to explore what was out there. Some barcode technologies, when we started looking, provided visual and audible feedback at preparation and administration, but we realized that it's not practical in all settings. But we started our goals to try to move forward at the preparation process. Next. So safety in a perioperative environment. We turned to our vendor, in this case it was Codonics, and we said we wanted to find the best way to scan these medications. So scanning helps us to have each individual vial labeled, concentration as the source of truth using the NDC system, and the barcode will then generate onto a label that we can put onto syringes. As you all know, that 95% of almost everything drawn up in the OR is a clear liquid. So if you drew up 5 or 6 clear liquid syringes, the potential for safety of what was being administered is tremendous. So today, 11,000 operating rooms are using barcode technology. And so that's 1.1 million potential medication errors reduced. Next slide. So the label itself is the key to this as in preparation. So what we started looking at was the Joint Commission's National Patient Safety Goals of labeling each specific syringe. And as you can see, the drug name, 2D barcode, who the preparer was, and all of this is data elements. And we'll talk about data in the future. So when Joint Commission came and did an initial survey in our OR at Texas Children's, we had handwritten labels and we were told we needed a corrective action. We then put that corrective action by using our label printers, by implementing that technology. And we were given 2 validations from Joint Commission on 2 separate surveys as best practice in our OR settings. Next slide. So how does this all tie together? So we talked about preparation. Now we've started moving forward with how do we get that integrated into the implementation of administration. We all know that we've focused on patient safety at the bedside by using BCMA. So how can we not try to use that functionality in the OR setting? So some of the challenges that we're having with is, how do you scan it directly into the EMR? Well, the good thing is our vendor partners have kept up with us. Now, they are driving with us to get towards that future of patient safety. And that responsibility is now partially on us as well as them. So in an OR setting, imagine, if you will, you've done the preparation right with a barcode scan syringe. You just have to, as you're moving towards your port, scan the barcode right over the barcode scanner, like at a grocery store, and you will be able to capture that documentation. So at the summit, we had lots of discussion about this, and we said this probably is not going to happen right away, but I think it's going to take some early early explorers to try to look and switch the paradigm and say, how can we enable this to happen? How are we so effectively looking at scanning patient medications in a nursing setting, and where we are being held to a standard of 95%, but we don't have an answer inside the ORs. Next slide. So we could take that even further. You know, the challenges of scanning, now that you have this tracking, you can actually do safety beyond the patient administration by capturing waste, looking at assay analysis from the barcode scans. So these pieces of technology, our vendor partners are starting to tie together to reduce some of the overhead that may free up the time to do some of these extra steps within the OR. Next. So infusions, that's the next level. So if you're a practitioner, you've been inside an OR, in many places it's dim, it's lit, and what you see on your smart pump is a small programming keyboard. Now the chances of making mistakes is high. It's a transcription error waiting to happen. So why wouldn't you be able to look at a potential of being able to scan your syringe and having the pump programmed? So that's what we are currently doing at Texas Children's, working towards that future by moving into our smart pumps and pushing that information through. So with technology, that's possible. We're reducing those error steps and increasing the safety to the patient. So safer operation through pumps, through auto programming, accurate documentation, automated documentation once infusion is started. So all of the systems are linked. In the past, you had to do everything in multiple systems. And now you're trying, we are really having great cooperation amongst our partners to improve the function to where we're reducing some of the human steps, right? In the human steps, we have so many potential error points for error. Next slide. So the neat thing that people ask us, and we just, Ismb put out an alert recently about this, is how do we take these types of technologies and take it further to reduce error? We've started using the same labeling system to have multiple syringes on different concentrations, different colors. So it gives our healthcare providers the potential to give the right administration to the patient based upon the age. So it's not a one-step process, meaning that we're not tied to just using printers and inside the OR, but we can use that same technology in multiple places to help identify a good return on investment. Next slide. So the neatest thing about this is that we start getting data. I mean, I think one of the greatest pieces of advancement in technology in the last 5 to 10 years is that we've always had data. We didn't know what to do with it. We collect the data. We pull that information straight out of these smart devices and pull it into dashboards to let the quality teams review how many administrations of a dose, how many near misses did we have, how many documented injections or documented administrations, and how many did we use to label. So we can look at variances. So we can say, why is one unit administering only 35 doses of a drug, but drawing up 70? That helps go back and ask the questions, understanding practices. And we'll talk about that a little bit at the end. Next. We also provide this out to our, as a little bit of competition. This data is out there. Early on, we provided this information to our anesthesia quality safety team to look at which providers were actually doing the most labeling. And it became a really friendly competition for improvement of safety, because when you know that you're using the syringe data technology to generate a barcode label to do administration, that challenges people around you to get better. Interestingly enough, when we started early in 2011, 2012, putting these machines in, we were told, oh, that's just another step. Now in 2021, the ORs consider that as a vital piece of equipment. If it's down, we in pharmacy get a call. The technology team pharmacy supports it to help them solve the problem. Next slide. So Christina Barnes, she's director of pharmacy service at Avita Health Systems. And I take this quote, and I really took this to heart. And I think this is something, she has a wonderful video out there if you ever want to go watch it, but I didn't have enough time to put the video. But she quotes, we have to take the responsibility that we don't cause harm to our patients. When you know a technology's out there, it becomes your responsibility to make sure you're not causing harm to your patients by choosing not to implement it. I think that's where we get into struggles. Next. So what is the price you would pay for patient safety? A lot of people ask this question, but just look at the headlines here. And this is a recent one in 2018. Patient safety issues could drive $383 billion in healthcare costs. So I ask every one of you on the call, look around you. If you look at a color laser printer in your healthcare facility, the label printers to support safety in an OR are almost most probably close to, if not less than the cost of those color label printers. Now, how do we justify color label printers, and why do we not justify patient printers inside the OR? Next. I think the answer really comes to this, right? Eric Hollingel, he's an interesting read. It's a good book if you want to take it. It's called Safety 2 Principles. The basic principle is called the ETTO principle. And that principle basically looks at is efficiency, thoroughness, trade-off. And when we were at the summit, one of the biggest comments that I heard with the clinicians that are practicing in the ORs is that the pressure from from hospital administration to turn the rooms. So if you had to take thoroughness, that means be as thorough as possible, you're going to give up efficiency. But if you want to be efficient, then thoroughness is going to be given up. So the fallacy in that whole thing is we're required to be both efficient and thorough at the same time. And that has its flaws in and of itself. So the thing that we as leaders, as practitioners, as pharmacists, have to remember, the work is imagined and the work that's done is totally separate. If you really dig deep down to it, it is not as imagined as how the work gets done. So what really happens, do you know? So that's a key here. Next slide. So where do we go from here? Right? And that comes down to how fast is technology accelerating? We started in the 1400s with a printing press, and we've put a man on the moon in 1950, and that scale is going up. First 3D chips, 3D movies. It is amazing, the technology around you. When we sit and talk about technology and patient safety, how much have we really advanced? If it took us 10 years to finally get at Texas Children's, to finally get the label printers in all of our ORs, how long is it before we make that a standard? One of the things that I always talk about, and been in the pharmacy world for almost 30 years now, is that we seem to look at safety with a price of a patient's harm. We change things because somebody tells us to do it. So I challenge each and every one of you today listening, talk to the people at your facility, talk to each other to see how we can improve the lives of our patients. They are put in our care, as everyone knows. So we should be doing everything that we can to our utmost to prevent harm to them. Next. Thank you.
Well, thank you to Julie, Judy, and G for a very informative symposium. We do have some time to take some questions before we end the program, and we do have a number of questions in the question box. So I'm going to start, and I think I'll start with Judy. This is a question about the self-assessment. Do you feel it's feasible to use the self-assessment tool to help design processes for a new, yet to be opened ambulatory surgery center?
Yes, I do. Each of those 221 best practices are out there to help you design each of the processes and the systems and the policies and procedures that you're going to create to open the new ambulatory surgery center. So they're all applicable to ambulatory surgery centers, or there's a not applicable scoring guideline associated with them. So you can see which ones might not be applicable. But yes, I would definitely use it because it lays out the best practices. One of the reasons that we put out the very first self-assessment in 2000 is so that we can get the word out about good ideas, best practices that were associated with hospitals at the time, hospital medication safety. And this does the same thing. This achieves the same goal. It gives you the best practices associated with medication use in the perioperative setting. So I would use it as a way to design, proactively design your ASC system.
Great, thanks for that answer. I'm going to go to Julie next. Julie, this question is for you from a CRNA perspective. Which specific barcode scanning processes do you believe have the greatest value added for medication safety in the OR without impeding that anesthesia workflow and patient care? So would it be patient identification, medication selection, medication administration, something related to medication preparation? Do you have any thoughts on that?
So I would say that medication preparation is probably the area that's been most widely addressed and implemented so far, and it does not impede or increase the workflow or workload at all. The easiest to address after that is probably scanning the patient armband barcode to correctly identify the patient. If you have electronic health record, the area that I see that at the summit we kind of addressed, but seems to be of greatest challenge is addressing the actual administration process. The need for there's a need for a double check. If there was I say need, but if somebody goes to administer something, they've already mentally decided what they're going to do, and they pick up what they think they're picking up. And sometimes that process is very routine. And if in that routine, there's not something, whether that's a flash or an auditory, something to remind them of what they're administering, the time frame you have to correct it at that point is incredibly short. And that is probably the place that has the fewest solutions at the moment and the most need for progress.
Yeah,
I don't know if
thanks.
G has comment to that too, but that's kind of what I see.
Yeah, and you know what, Julie, there is a sort of related question that was in the chat as well. And how do you suggest doing barcoding when the armband for the patient is often tucked and not accessible? And I don't know, maybe G, you even have a comment on that.
At the beginning of the patient that's on the table is not going to change through the process of the surgery. We only have one patient during the surgery. So I think as long as you barcode at the beginning of the surgery, if you need to, then the barcode needs to maintain through the procedure so that it can, if you're giving blood or you're double checking, you have that available for double check. Some have suggested putting an armband on an IV pole or at the computer, but there is always the chance that then between cases that armband doesn't get moved. So I would strongly suggest not duplicating where the armband is located, but scan it once and then maintain the patient. That would be my answer.
Good suggestion. G, do you have anything that you'd like to add on that question?
No, I agree with Julie on that. I think you scan it once, you double check it at that point. The patient barcode is taken care of. I think it's the administration piece.
So
Yes,
G,
and I agree also.
go ahead.
I
Thanks,
think
Julie.
I think you should really scan the patient, identify the patient through the initial process, and then, like Julie said, the patient doesn't change. So you scan it once at the very beginning. We know that that armband is tucked away at some point and not accessible.
Yeah. So G, here's a question for you. Are there any learnings or any pain points that you could share in your journey of implementing these colored medication labels? And can you share sort of what might be the most challenging issues that you had with implementing that change?
I think initially is to make sure that you put together a good core team of anesthesiologists, nurses, and pharmacists. And the challenge actually initially is who's going to be responsible. So in our institution, we decided right away, pharmacy takes care of almost all parts of medication management, and we're not going to shy away from this area as well. So we took it on as part of our budget. We took it on as part of our oversight and management. And then we actually doubled down and put technology behind it and pulled the data back in. So challenges would be by itself. I see that, just it's not a plug and play thing. You'd have to put some time into it. But once you put the time into it, the early adopters like us have started capturing data and can provide that back. And I keep emphasizing data is the key to change. And we are going to continue to do it. There was another question similar to this about how do you keep managing the information when there's a new NDC added. Well, that we have that same technology. We have the tool actually can generate and upload information. And we've automated the process that if you scan it, we automatically pull the information on our Codonics label printers, because we can use wireless technology or we can pull manually, but we look for the wireless technology to pull that information back. And we print out a report that says, hey, this came up with a no scan label. And we're able to update that through pushes. So once again, using the available technology out there to solve some of these problems, but it takes some time and effort and planning. But once again, if you have the capability, I strongly suggest you try to move forward with it.
Thanks, G. So I'm going to direct this to Julie, but if any one of our three speakers wants to comment, and there's a couple questions related to barcode use of medications that are passed to the sterile field or used by the circulator nurse. Is anybody out there doing something with barcoding of those medications? We focused a lot on anesthesia in our discussions today.
The answer to that is that there are not many, but yes, there are people doing barcoding from the sterile field. Somebody, I don't remember who at the summit mentioned it a few weeks ago, but somebody at the summit said they were in fact barcoding as they place things on the sterile field. And it went straight to their EHR. Do you guys remember who that was? But somebody said they definitely were. You can. It was not Epic that they were using. I want to say that it was a different EHR.
Any other follow-up comments from G or Judy?
You can do the sterile field barcoding if you use the Epic functionality that ties to one-step medication. Choose the other med and then scan the medication at administration before it happens. So the BCMA process can happen. Now, enforcing that and getting it to happen are two different stories.
Just a staffing question I'm going to ask you. This is directed to you, G. Do you have any dedicated pharmacist or pharmacy technician FTEs in the OR or perioperative setting?
We have pharmacists and technicians in the OR setting that's dedicated to taking care of those ORs. So in our CVICU and our ICU locations. And we have a pharmacist and a technician that maintain the technology as part of the partnership to include resolution to problems.
And about, do you have an FTE, like a ballpark of how many FTs that might be?
We know we probably have a half a pharmacist, probably a quarter of a pharmacist to take care of the technology side, one FTE to take care of the technology piece. And then we have multiple FTEs in the OR, but they're servicing more than just the anesthesia provider. They're also providing services to the surgeon at that time or nursing. So sterile field preparations.
Got it. Great. Julie, this is somebody looking for you to comment on this. Would you discourage the practice of nursing staff routinely accessing the anesthesia drug trade drawer for moderate sedation case medications?
Yes.
Thanks.
Most moderate sedation cases, most nurses access medications from an ADC specific to their case and would access a crash cart or something if they need emergency medications, because the nurses themselves can't just decide to give those medicines on, should not be deciding and cannot decide to give those medicines on their own.
Okay. So we have a question about the best practice for reviewing smart pump data in the OR. Is anybody looking at infusion programming and anesthesia mode to determine what was infused in the OR versus other areas? And I guess that, G, go ahead, thanks.
Yeah, so we've started our journey to interoperability with Epic and Alaris. So on the nursing side, we've put that in implementation. We're slowly moving into the OR side, but in preparation for this, we are pulling the information that comes to Alaris for what is being programmed manually. So we have that, and we've seen some irregularities between when the patient is in the OR and then post-op. So that is a big challenge. And I think integrating that piece to where it can be programmed off the same process and then documentation back into the EMR will be very influential on improving the patient safety for the patients. And we've noticed that nursing struggles with this as well, because what happens in the OR is not the same concentration that pharmacy can deliver post-OR. And then it puts the nurse having to do a basic infusion, which takes away all the safety from the pump. And so we really are encouraging capturing the data first. And then when we probably by spring or summer this year, we're going to integrate into the OR areas. And then when that loop is closed, I think we'll be able to provide lots of good data back.
Julie, do you have anything to add?
No, I think I would agree.
Great. Well, since we have 2 minutes left, I'm going to ask for the next slide. I want to thank everybody for attending. We are really so happy that you joined us today. I'd like to again thank our speakers, Julie, Judy, and G, and Pfizer for their sponsorship of the program. The materials that you received have this slide in it. It tells you how to obtain your continuing education credits. You will need the attendance code, which you see on the screen here, YGVDU4. And with that, I'd like to say thank you, and we hope you all have a wonderful day and a great meeting.